Well, good afternoon, and I want to thank the Illumination Foundation just for this great day and the opportunity to kind of do some closing remarks and close the day. I will say it's always a bit nerve-wracking to be all that's standing between you and the networking reception. But I wanted to provide a wrap-up of where all the many issues we heard from today fit in an evolving health and human service landscape. And bring, I hope, my perspectives as an analyst to how do, health policy, science, the current market environment, how are they going to really affect this path to health equity that everyone's been talking about today? And kind of answer the question, in every session I was very impressed that almost to a person, people ask, what can I do? What is the action item that would make us follow the path of Illumination Foundation and their front yard and do something about health equity? I think you have to start when you look at the changing environment to talk about the pandemic. And two things. One of them is, as Ms. Ryerson said in the opening today, I think the pandemic really laid bare the effects of health inequity on the population. I think it brought up for many people, it was the first time they had that real realization of the actual effects on American citizens of health inequity. So I think it raised awareness. But the other piece is the pandemic really did speed up the evolution of many things in the healthcare space. You heard Kara Carter today talk about, overnight telehealth became a reality. And in fact, that is true that we went from less than 1% of the population to almost 80% of the population getting services from telehealth. We sped up digital treatment. There was more of a focus on social determinants of health. So really in this closing, I want to do three things. I want to point out, I think, what are 5 big trends in the healthcare space that are going to have effects, both good and bad, on health equity. And I want to talk a little bit about the opportunities for innovation and some of the challenges that we see as if we're really going to move to a more equitable healthcare system. So let's charge ahead. I mentioned there were these 5 things. I want to focus on kind of the 5 big developments. Probably the single biggest one is that payers are much more focused on whole person care now than they were just a short time ago. And I always like to come back and say we have the Affordable Care Act to actually thank for that. I've been in healthcare a very long time. When I first got into the healthcare field, there was a lot of discussion in providing benefits about how to exclude people from benefits. The Affordable Care Act brought us no pre-existing condition clauses. It eliminated annual and lifetime limits. We got a much further down the path for behavioral health parity. And for the first time ever, health insuring organizations, payers, all started to look from a whole person perspective and try to come up with the first whole person solutions. Before then, we really had a lot of lip service around integration, but not a lot of action. So one of the big things in that change, post-pandemic, is we've seen this very big interest in new models for whole person care and addressing those needs. We've also had, just in the past couple years, a real focus on kind of moving away from, I would call it pay for volume. And you heard Clayton Chow just mention that in the last panel, that payers are looking for ways for how do I tie what I pay for services to actually that value that's delivered. And there are, I would say, where are we in this journey? When you've seen one contract, you've seen one contract. There are really lots of experimentation, which is sort of the American system way. It varies a lot by state. Just an interesting factoid for people who want something at their next cocktail party. When we do a lot of analysis of value-based contracts, there are 550 different measures of value just for mental health services. But we are seeing almost every payer kind of move down this path of less pay for volume, more pay for value, and trying to decide what does that mean. The digital health piece is probably the single biggest change that was brought to us by the pandemic. I mentioned we had, pre-pandemic, less than 1% of services delivered using some kind of digital platform. We think post-pandemic, it will drop from about 80% to 50%, but we don't see the digital era going away. We see it continuing. A couple interesting factoids. Our most recent data shows that of Medicaid, or in the case of California, Medi-Cal beneficiaries, 85% of those folks already have smartphones. And there's been some pretty good research that even people with cognitive and mental health disorders are actually, can use various functions in digital environments for therapy and for communication and participation in person-centered planning. So we've got, I think, laying the groundwork for how do we, as we look ahead, how can digital health fit into that health equity equation? But with it, and there was some reference to this in the last panel, we now see, and all of these things have happened over the past really 2 years, a massive investment in terms of private equity investment and a massive shift in creating digital healthcare delivery systems. So, and they range from standard insurance companies creating digital networks, private equity-backed primary care networks. There are probably 800 digital behavioral health networks that are out there. So it's a real shift in the market landscape in terms of who are the available providers for providing service and how do you access them. And then last but not least, the piece, I don't know what this means yet, but we are seeing the past 2 years major retail players actually expanding their footprint in the healthcare space, and I like to underscore the behavioral health space, the chronic disease management space. Amazon, Walmart, and CVS have probably been the most active, but what this means, I did some quick math. As we look ahead and read their plans, we're looking at retail locations opening between 20 and 40,000 new service delivery locations as part of this retail rollout in healthcare. And so these are, I would say, not necessarily factors. As an analyst, I look at it and say, I don't know if these are good or bad for health equity, but it certainly is going to change the landscape. So thinking about, kind of what are the upsides? One of them is, I think that this whole move towards integrated health is something that's providing great opportunities for people with new social interventions. In the past 2 years, it has been the first time we've seen major insurance companies, Humana, United, Aetna, actually paying for housing programs for the first time. So there's a huge interest in sort of the, what are we going to do in terms of affordability? How do we actually use healthcare resources to pay for housing and other social determinants of health? So we've got I would say the effects of that interest in integration is a big part of it. Value-based reimbursement has with it the potential to expand funding for social services and for housing. And I like to think that if you think about the model, right now, and Ms. Ryerson mentioned this in the opening, the US spends the most of any Western country on healthcare, but the least of any Western country on social services. And in some ways, the flexibility that we now see with value-based care, I think is probably a poor policy route, but a route that's available right now to try to balance that inequity between healthcare spending and social service spending. There are, I think, good things about the use of data. We heard all 4 sessions today talk about the power of data, the use of data in solving healthcare inequity problems. And I would say that the move to using big data and for diagnostics and for clinical decision support is a big piece in removing, I would say, kind of systematic prejudice about who has access to care, and a huge part of that equation. And then the last, I'm very hopeful that both retail healthcare and digital healthcare will provide new ways of providing access for previously underserved populations. So I think there are big advantages ahead and things that we can leverage. But I want to move to the other side of the equation. There are kind of 4 key things that I am most concerned about if we're looking at this path to healthcare equity along the way. The first is really, I would call it the basics. How do we get essentially literacy and access to good education? How do we deal with digital discrimination and lack of broadband access for a lot of the population? And as Mr. Watts said in his presentation, there's the whole issue of universal access to health care. And do we accomplish that through trying to get the last 12 states that haven't expanded Medicaid on board with that? Or are we looking at a different path in terms of Medicare for all or some other universal access model? But there is the basics of that piece. The second challenge, I think, is really in trying to apply diversity to a lot of healthcare policy decisions. And I'll give you just a couple examples. We had Dr. Abrams mentioned the need to try to quantify the needs of populations and tie that, essentially the statistics for vulnerable populations, to reimbursement. And if you think about the data, we have about 6% of the population in any health system, whether we're talking Medicaid, Medicare, a health plan, 6% of the population uses about 50% of the resources. Trying to develop reimbursement mechanisms, both for health plans and for providers, that actually take that differential in need into account is a huge part of moving down that path to health equity. Another key area is really the use of information about diversity in making decisions about treatment and treatment algorithms. We are still at a place where the approval of pharmaceutical agents by the FDA is largely done by random controlled trials that are conducted mostly on white men. And we're seeing this now. There are 7 new digital treatments that have been approved by the FDA. They're really all using the same standard of care. And we're going to want to think about long-term in terms of equity. How do we actually bring diversity into the discussion? And then I would be remiss if I didn't say, kind of building on Dr. Abrams' point, as we move to value-based care, the definition of value is a political construct. What is value? How do you measure value? And I would say particularly when you're looking at Medicaid data, health plan data, being able to disaggregate outcomes, consumer experience, and some of the other key metrics by ethnic groups, by particular cohorts in the population, is going to be essential if we're going to make value-based care actually equitable for the broader part of the population. So there are I think some real challenges ahead in the application of that data. And then the last, I would say the other point regarding data and kind of how we're going to advocate for the most vulnerable populations is something that is a hot topic right now in California, which is how do you decide who actually has access to what care in a health plan? How do you develop medical necessity criteria, clinical appropriateness criteria? What's the social context for that? And here's where lived expertise and essentially team-based decision-making can be a huge asset in trying to operationalize those health plan decisions and who gets access to what kind of care. Last but not least, I would be remiss if I didn't talk about, even for people with insurance, there are huge issues in terms of health equity. And they fall in a couple categories. Primarily, though, it really is that we have very large copayment and cost-sharing requirements for people in Medicare and in people on exchange plans. Currently, they estimate, and this number is head-spinning to me, the typical person who goes on Medicare at 65 will need $100,000 in cash to pay for out-of-pocket expenses not covered by the Medicare plan. And you start thinking about kind of that burden. What the data shows us is we see lots of care that is avoided, prescriptions that aren't filled. because of the copay requirements in both Medicare and the exchange plans. So these are all, I am, how would I put it? I am very optimistic about the tools we have now, I think much better than the 30 years ago when I started in the healthcare field, to actually address a lot of the health equity issues. But I do think it's going to take the efforts of lots of engaged people in the healthcare field to, how would I put this, to actually sort through all of the big policy pronouncements and get down to the devil in the details when it comes to actually operationalizing health policy at the ground level. And I wanted to end with actually a favorite quote of mine, and I think it really does apply to all the conversations I've had here today, and that is, the obstacle in the path becomes the path. Never forget, within every obstacle is the opportunity to improve our condition. And I really want to thank Paul, the Illumination Foundation, for putting on this great event and giving me the opportunity to both meet so many people and hopefully start down that path to health equity. So thank you very much.